All right, we will go ahead and get started. Thank you so much, everybody, for joining. This training is hosted by the Ohio chapter of the American Academy of Pediatrics under the Parenting at Mealtime and Playtime program. In its 22nd year of funding, the Parenting at Mealtime and Playtime program has provided evidence-based education to physicians, nurses, home visitors, community health workers, and beyond. The Ohio AAP is excited to continue the work of PMP and looks forward to diversifying its audience and topics. If you have any ideas for the program throughout today's session, please share your ideas in the chat or reach out to me, the PMP program manager. We always appreciate feedback from our learners. Slides from today's session will be shared in a follow-up email. A bit of housekeeping, if you could please keep your camera and audio off throughout the session, we would greatly appreciate it. Next slide, please. Thank you to our funder, the Ohio Department of Health, for funding this education session and supporting the health and wellness of children in Ohio. Next slide, please. The planners, faculty, and others in control of the content have no relevant financial relationships with ineligible companies. We have considered the Ohio AAP Speaker Toolkit standards in preparing this presentation. It is our intent to foster respect, belonging, support, and accountability with regard to the patients we serve. If you have any concerns or comments, please contact Dr. Kelsey Logan at the email listed on the slide. Next slide, please. With that, today's training is hosted by Dr. Baba Priyamani and Dr. Roy Kim. Dr. Mani is a pediatric endocrinology fellow at Cincinnati Children's Hospital. She received her medical training from St. John's Medical College in India and completed her residency at Case Western Reserve University and Metro Health Medical Center in Cleveland. Dr. Kim is a pediatric endocrinologist with Cleveland Clinic Children's. He is board certified in pediatrics and pediatric oncology and received his and received his medical education at the University of North Carolina, Chapel Hill. He completed his residency at the Cleveland Clinic and fellowship at Children's Hospital of Philadelphia. Thank you so much, Dr. Mani and Dr. Kim, and I will pass it off to you.
All right. Thank you, Suhavi. Thank you to Dr. Adams, too, and her program, Parenting at Mealtime and Playtime, and also the Ohio Department of Health. Dr. Mani and I are thrilled to be here to talk to you about our topic today. And before Dr. Mani begins, I wanted to sort of set the stage a little bit for the reasons why we wanted to present on this topic. Of course, we know that pediatric obesity is a major public health problem. And what's been exciting recently is how much the field has evolved in terms of our understanding of the biological roots of the condition, as well as the social and environmental determinants of obesity risk. This has led to new treatments, both in terms of lifestyle, new medications, and bariatric surgery as well. In spite of all these advances, the most recent AAP guidelines for the treatment of childhood obesity still maintain that lifestyle interventions are foundational. And so that is really the context for our talk today. We want to really provide some practical tools to help us in our clinical encounters as far as lifestyle interventions go. So we hope that this talk is relatively concise and short, that it is fun and interactive, and also very practical for you. In the chat, we may post some links that we would invite you to either open up as we present or spend some more time with later on. And with that, I will turn over the objectives talk to Dr. Mani.
Thank you, Dr. Kim, and I appreciate this opportunity, and thank you to the organizers, sponsors, and everybody else. Our objectives for today are to understand common eating behavior phenotypes that are associated with childhood obesity, how to assess for these in a busy primary care clinic, and to look at evidence-based interventions and how to apply them in a primary care clinic. Next slide, please. Okay. So the prevalence of obesity has been increasing over the past several decades. About a decade ago, the prevalence was around 13 to 15% in adolescents, whereas now it's closer to 20%. So the latest guidelines show that 1 in 5 children and adolescents in the United States have obesity. Obesity is a chronic medical condition and should be dealt with as such. Unfortunately, a lot of stigma still exists around it, and we have tools that we can share with you on how to even begin discussing obesity in a family, being mindful of the stigma and barriers they might be facing. So obesity does affect certain groups more than others. Hispanic and non-Hispanic African American children, as well as families with lower incomes, tend to have more prevalence of obesity than their counterparts. Next point, please. As we all know, healthcare for obesity is expensive, both for the patients and the healthcare system as a whole. However, obesity, if not addressed appropriately, can lead to several comorbidities and long-term complications. So risks, so to alleviate risks, we recommend early intervention, and studies have shown that it has long-term benefits. Next slide, please. So the AAP 2023 guidelines, which I have just posted a link to in the chat, as Dr. Kim alluded to, still emphasize intensive lifestyle and behavioral treatment as the first-line obesity therapy. There is a figure in the guidelines. It's figure 3, which actually talks about what IHBLT is beautifully. So it talks about the who, the what, the where, the when. So how to approach patients, how long, etc. A key takeaway from that is there needs to be contact with the patient and family for a longer period of time. So at least 3 to 12 months and a total of at least 26 hours to lead to significant improvements in BMI. Throughout our talk, we'll focus on the what. So what exactly are we doing during those 26 hours of contact with the patient and their family will be the focus of our talk. There's, of course, still need for targeted interventions and several gaps in our understanding of effective behavioral interventions and how to implement them effectively in a primary care setting, being mindful of how busy it can get. So our talk today, like I said, will focus on different eating behavior phenotypes that can hinder healthy lifestyle adoption and how and what interventions we can do at the primary care level to target these. We won't be discussing medications or bariatric surgeries, but those are still options available. Next slide, please. Dr. Kim.
Okay. Thank you, Dr. Mani. So this will be the framework for our talk. If you were to search Control F and search for table 21 in that document, you will see illustrated the gaps that the panel found in our understanding of the roots of obesity and interventions. And if you scroll down to treatment, you'll see bullet point 5 and 6 address specifically the gaps in our lifestyle interventions. So we know about the need for a sustained treatment, and 26 contact hours seems to be a threshold. We know about counseling of generally healthy diets. But the purpose of our talk is to really, maybe for that return visit after our initial interventions have been delivered, and maybe a family, they're still struggling to reach a healthier weight. So we want to provide some tools to really look more specifically at the unique nature of the child's eating behaviors. And so this framework shows the behaviors that we'll be talking about today. The first one being food fussiness or picky eating, really common issue that we'll spend some time talking about. Fast eating, we'll cover briefly. There is less time, for example, at school for kids to eat. Tendency to eat quickly can lead to problems with energy balance. And we think about children and adults really eating out of a sense of hunger, but hunger is not the only cue for food-seeking behavior. So we want to talk about kids who eat due to hunger and have really high hunger drives, but also recognize that kids also eat for non-hunger cues, and that's also true for adults. And identifying that can be a really useful insight to guide our conversations. So our first case is that of an 8-year-old girl. She has a high body weight. Her parent says she's very picky and won't eat any vegetables. Her diet consists mostly of chicken nuggets, fries, some sweetened drinks, and she tends to refuse any vegetables and also most fruits. And her parents say that she has been this way since toddlerhood. As a family, they tend not to eat together, and the parents will often sort of give in and give the child preferred foods to avoid meltdowns, but also so she'll eat something because they're concerned that if she doesn't like the food, she won't eat at all. So we want to use this case to really discuss practical ways to assess food fussiness in clinic, and then also highlight things we can do in terms of prevention and treatment of established food fussiness. So researchers define food fussiness or picky eating as a refusal to eat a wide variety of foods. And children who have this tend to eat a very restricted diet, and it's not due to any kind of food allergy or medical or metabolic intolerance of the food. And we see this very commonly in obesity clinic. At a population level, this eating phenotype tends to be associated with lower body weight, is what the research finds. But when we see it in obesity clinic, it makes it very hard for children to adopt healthier eating practices. In obesity clinic, it's associated with poor diet quality, and the food that goes by the wayside is usually vegetables. It's also recently been found to be associated with a higher intake of ultra-processed foods. So those are foods that are subject to the addition of things like preservatives or extra sweeteners or stabilizers, and tend to be correlated with foods that are higher calorie and of lower nutritional quality. Not always, but often. So there are some data about what are risk factors for the development of food fussiness. And from a biological standpoint, it's been found that things like amniotic fluid composition, breast milk composition can sort of predict food fussiness later in life. The timing of introduction of complementary feeding can also be a factor. And also, as we alluded to, the structure of how the child and family eat can also influence food acceptance. So we've said that food fussiness is really synonymous with picky eating. One sort of variation on food fussiness is called food neophobia, which specifically refers to a refusal to try new foods. And so sometimes the ability to tease out these different aspects of food fussiness can impact the interventions that we try. So researchers who first described, from a psychometric standpoint, food fussiness, use this tool called the Child Eating Behavior Questionnaire. And it is a 35-item questionnaire, and in terms of questionnaires, it's not super long, but it's pretty long. And they asked several questions such as these. My child enjoys a wide variety of foods. My child is difficult to please with meals. And my child is interested in tasting foods she hasn't tasted before. And the parent rates their responses using a 5-point scale. And it was determined that a profile of 4 or 5 of these types of questions correlated with sort of our common sense definition of food fussiness. We can't, in a clinical setting, administer this sort of questionnaire. And fortunately, other researchers also found that, a common sense approach and just asking a parent, is your child a picky eater, does a reasonably good job, fortunately, of identifying fussy eaters, picky eaters. And we can kind of flesh that out more, maybe by borrowing questions from the questionnaire. But in this instance, a simple history can help identify these children who could benefit from a specific intervention. This table shows things that can be done to both prevent and manage food fussiness. And the first few lines really relate to anticipatory guidance practices. And even before, with preconception counseling, we can encourage mothers to be families where a child is planned, to encourage the mom to have a very diverse diet in terms of different flavors. And this is for mothers who are pregnant as well as nursing. So encouraging them to have foods that include bitter items like vegetables, spicy foods, umami foods, just different things to expose the fetus as well as the nursing infant to different flavors has been shown to enhance their food acceptance later in childhood. Also, the timing of complementary feeding, really trying to target about 6 months, can increase food acceptance, and waiting too long in particular can cultivate picky eating. Introducing foods of different textures, coarse foods, lumpy foods, trying not to maybe puree everything can also increase food acceptance. And then when introducing baby foods, trying to encourage, the introduction of proteins and vegetables before a lot of sweeter vegetables or fruits are introduced. We also believe that structured family meals can increase food acceptance. Having dinner together as a family and with the TV off can increase food acceptance. And this may be mediated by children observing their parent or parents eating a wide variety of foods. This sort of effect may be mediated by increased family cohesion, as well as role modeling by the parents, and also an aspect of rule acceptance, that these are just healthy foods and these are things that are eaten, and it's not a big deal to do so. So it can be very difficult, though, to treat established picky eating. And we tell families not to give up, that they should know that it may take 10 or 20 exposures to a food before there's the beginning of food acceptance. We think in this instance, when a food is not being accepted, to change food preparation technique, to add things like sauces and sometimes mild sweeteners or sometimes extra salt to enhance the acceptance of those foods. I think in practice, if a child wants to have carrot sticks and they want full fat ranch dressing, that's okay, because it at least opens that door for them to try and accept new foods into their diet. This is also a situation where it's okay to play with your food. Research has found that children who are allowed to sort of handle new foods, smell them, play with them, even without eating them, that over time this cultivates a greater acceptance of these foods, and maybe the next time they're exposed to it, they'll actually eat it. And there are also interventions that are school-based or family-based that involve things like shopping and doing the food preparation together that have shown benefits in this area. At this time, I would welcome anyone to chime in either on the chat or by unmuting and turning on your camera to suggest things that you have done, maybe to increase food acceptance amongst your patients or maybe with your kids too. And in this way, we can kind of learn from each other as well.
I'll share. If it's age appropriate, I find toothpicks are really fun, right? There's safety, of course, that you have to, this is not for toddlers, but for older kids, especially if they have a different device or something that they can enjoy with toothpicks, it feels much more inviting. And it tends to be a lot of fun.
Thank you for that. That's excellent. Some comments in the chat. Baby-led weaning helped to increase food acceptance. So tell me what baby-led weaning is.
Of having babies at 6 months when they are introducing solid foods, actually feeding themselves by putting their hand in the food and either licking it off their fingers if it's something soft like oatmeal, or picking up things like, say a green bean that's cooked sloppy soft and chewing it up and swallowing.
That's great. I don't, honestly, I don't know the data on that, but I think it really is in line with the idea of letting kids sort of have a multisensory experience with the food, not tasting it, but also handling it too.
I think the biggest drawback to it is babies tend to gag a little bit, and parents will interpret that as choking, and then or the baby spitting the food out and them not liking it. So reassuring a parent that gagging is good, they're just figuring out how to transfer food from the front of their mouth to the back of their mouth, I think is the hardest selling point on like that approach.
That's great. And then other comments. Ellen writes that kids can pick out taste test foods at the grocery. Yeah, so enlisting the child to help choose what vegetables they're going to get at the grocery store. Having a garden, I think there's nothing like that where they can pick it and then eat it fresh off the vine. And Gislo writes that taste buds are forming all the time. So I think that is very important. Telling families just because your child didn't like it the first 5 times, maybe if you revisit it down the road, they're really going to like it. And so that's a good lesson for the kids to know that if they try it, they might like it this time. And then also for the parents too, that their child maybe didn't like it, but they might really not just accept it, but really experience it in a different way when they try it later on. Yeah, and then Sarah writes that the kids can smell their food, lick it. They don't have to necessarily swallow it though. So that really, I think it goes along with that idea of sort of desensitizing a food that the first time they're exposed to it, they're like, what is this? But over time, they can grow to be more comfortable with it and sort of reduce what sometimes is like an aversion to a new texture or flavor. And limiting snacking, I think maybe having greater hunger might open a child to trying new things. And then including a child in the preparation, because I think that, I think if a child sees the food evolve during the food preparation process, they may be more likely to enjoy eating it and say, I'm eating something that came from my own hand. Thank you for those comments. And then Melissa writes, we talk about describing the food, color, smell, texture, temperature, and think about a change that they would be interested in trying. In other words, strawberry, if they don't like the texture, how does it change if it's frozen or blended? Yeah, so we have a psychologist in our weight management program who walked us through like a mindful eating technique. And so this reminds me of that. So instead of eating your food and just kind of gulping it down, to really chew it and experience it, and having a mindful approach to what that eating experience is like. And then how would it change if we transform that food? Thank you. Okay, Dr. Mani.
Thank you. So now for case 2, we have a 10-year-old boy who comes to clinic with chief concern of eating a lot and gaining weight quickly. We gather more history. Parent reports that the child finishes his meals much faster than they would expect and often asks for seconds. When we look at his growth chart, his BMI is at the 97th percentile. And when we take more of a social history, the family tells us that while they eat together, they usually have the TV going and are watching it while they eat. The boy has no other medical conditions and is not on any medication. So, as a starting point, we're going to discuss how to assess for eating speed and what is fast eating. And then pivot to a vital question. Why does that matter? Oh, next slide, please. And then finally, we'll end with some strategies to combat speed eating. Next slide, please. Okay. So, sorry. Could you hit? So, what is fast eating? Yeah, could you hit the? Oh, I'm sorry. Next slide, please. I apologize. I think there should be something that shows up before the table. I apologize for the tech error.
Yeah. Okay, wait. Oh, there it is.
There we go. All right. So, kids that eat faster tend to have a higher BMI on average, as well as vice versa. If you compare children that are obese with those that are not, the children that have obesity are more likely to be fast eaters. Fast eating is also associated with developing obesity later in life. And in adults who are fast eaters, they tend to develop obesity as well. So it's not limited to childhood. There could be several factors for why a child or even an adult is a fast eater, and some of them are more social factors that we can't really control. Like in the beginning, we talked about school lunch breaks being 20 or 30 minutes, and we know children want to do other things during that time, so it's quite likely they just eat quickly and then move on to play or do other things. It's important to know that eating for at least 20 minutes is necessary to actually feel fullness, because it takes at least that much time for the food to enter your stomach, gastric distension, neurosignaling, and actually feeling satiety. So I think one that leads to one of the approaches is to ensure that we have enough time and a meal is not rushed, so at least 20 minutes. So asking a question, does your child eat faster than normal, is a good way to start because parents usually notice this. The other approach we can do to deal with a fast eater is increasing the number of chews per mouth of food. So research has actually shown that going from 15 chews to 30 to 40 significantly decreases the amount of food eaten. I will say it's not very easy to discuss this in clinic, so we always begin by acknowledging that it's unnatural to count how many times you're chewing your food. And you don't have to do it for every single meal or for the entire meal even. I think even just doing it for the first several spoons or first several bites makes children more conscious and more mindful of what they are doing. And overall can help them like calibrate how much they eat and how quickly they eat. The third strategy we can do is place the fork or spoon down between meals. I mean, between bites of food during the meal, and actually being like mindful while eating. So not eating in front of the television or with phones. I see some comments in the chat. My grandmother told us to chew our food at least 16 times. Yes, for sure. I'd say even more than that would be better. And then a simple trick, have the child drink all of their drink first, leads to an earlier sense of satiety. I think that's a great point. Of course, we have to be mindful of what the drink is, if it's water versus being juice. So I think it ties into a few things, but it's an excellent point as well. Next slide, please. So this is the same case. We're going to look at it from a slightly different angle. So we've just highlighted that the boy eats a lot and often asks for seconds. And we're going to discuss a few questions. So one, do all children with obesity eat a lot? Simple answer is no. Several children with obesity probably eat more than typical, but we've all seen it in our clinics where we have children with obesity who don't eat as much. So I think quality of the food and choice of food, types of food is equally important to how much food they're eating. So that brings us to another concept called satiety responsiveness. It's basically, do they feel full or not? There are scales that exist, but it's much easier to use, as Dr. Kim said, a common sense approach and ask if they're finding it hard to feel full or are they just never full and they keep eating. So in these cases, we have some strategies we can use. So a glycemic index, just for completion, it's a number assigned to a food, but basically looks at how quickly the food spikes your blood sugar, to what degree it spikes your blood sugar, and how long the effect stays. So we actually want what we call lower glycemic index foods, which don't cause such a big spike and which also stay in your system longer. So protein, fiber, fats, be mindful of the type of fat. We want polyunsaturated fats are okay, but like saturated fats should still be limited. But these are foods that are lower glycemic index and also tend to be higher satiety, as opposed to fast acting, like a juice box, for example, is extremely high glycemic index and pretty low satiety. The last thing I want to highlight is studies have consistently demonstrated that eating breakfast leads to better satiety for the rest of the day and less eating overall. Next slide, please. Okay, Dr. Kim.
Okay, yeah. Case 3. So case 3, our patient is a 9-year-old girl who has an elevated BMI, and the parents report that she is eating all of the time. They report that even soon after having a meal, she's starting to think about eating again and requesting snacks. They do note that she seems to eat when she's bored and also stressed, and that she really likes sweets. So we wanted to use this case to really encourage us when we're seeing our patients to not just ask about like the quantity of eating, but also the situations where the children are doing the eating. It may not always be at mealtime and may not always be related to hunger. So we call this phenomenon in the field of obesity research, it's called eating in the absence of hunger. And it is, along with the sense of hunger and fullness, another trigger for food-seeking behavior. So totally unrelated to the usual hunger cues or fullness cues. And we've talked a little bit about increasing satiety and addressing hunger with the previous case. So we also want to talk about what strategies are available to combat eating in the absence of hunger. How do we tease out what the food-seeking triggers are? And by identifying those, that naturally leads to an intervention. So eating in the absence of hunger for some kids can be due to the simple fact that they just like eating. It's not that they're hungry. It's not related to them not wanting to eat because they just ate something. They just love the sensory experience or the hedonic properties of eating food. So often there are kids who like eating all kinds of things, but not always. But they often have wider food acceptance than the picky eaters. But there are also kids who eat without hunger as a response to some psychic state. Either they're bored or they're stressed about something. And sometimes it's because they're very tired as well. So this type of eating has been called external eating. So the idea that our eating isn't due to hunger, but maybe our environment or maybe external stressors that we're responding to. And this general phenotype of eating in the absence of hunger is associated over the long term with increased energy intake, so positive energy balance, higher body fat percentage, and also increased rates of obesity. So that first group of kids, those kids who just like the hedonic properties of eating, who will seek out food if they know it's in the house, this has been called food responsiveness and is also characterized by certain items in that eating behavior questionnaire. And so there are things we can do to sort of further tease out, what the triggers for food seeking are. And some of these questions might be things like, do you feel like your child eats really when they're not hungry? Did they just have a meal and they're thinking about eating again soon? So sometimes that is because they're actually having a quick return of hunger, but not always. So the next question, does your child just like eating everything and are they not picky? So they are food responsive children. And that can be a cue to sort of capitalize and use their love of food to maybe shift what they're eating and focus on healthier food and less calorie dense types of food. I'm going to jump to the last point. We do ask kids, ask their parents too, do you feel like your child eats more when they're worried, anxious, or bored? And some parents are just like, yep, they're not hungry, they're just hanging around the house and the food's around. They don't have anything else to do, so they're eating. So sort of this lack of structure of eating lack of structure around meal times and increased access to food can lead to higher energy intake. During the COVID pandemic, for example, there were sharp increases in childhood obesity. So sort of the lack of structure, the boredom is thought to have increased food intake, not to mention the decrease in physical activity opportunities. But there was a sharp increase in obesity, and we're still kind of seeing the repercussions from that amongst the pediatric population. Okay, so, obviously when we identify these different triggers for eating, it can lead very directly to strategies to intervene. So, kids who eat when they're tired, for example. I mean, eating gives actually a little lift in alertness and in energy, although it's temporary, it's a real effect of eating. Also, staying up late and not going to bed, for a long period of time. You have normal circadian patterns of hunger and satiety. And if you just stay up long enough, you will start to get hungry, around 11 p.m. or midnight. So late eating often goes hand in hand with not having a regular bedtime and can be associated uh, with a return of hunger, more eating, and then if one is to go to sleep right after eating, there's some thought that that could be more metabolically harmful. Stress management, we think, is also an important approach to regulating our food intake. So children who do have a lot of anxiety, behavioral health intervention can help them. Behavioralists can help them with mindfulness approaches to eating, to really think about the experience of eating and listening to one's body's cues and to sort out things like fatigue, stress, and boredom from actual hunger. And in a simple way, children who eat when they're bored, some parents have really been good at identifying that and saying, well, go play outside or color in a coloring book and do that. And sometimes that's enough for the child to, at least temporarily, not ask for snacks. And that Ellen writes in the chat, so introduce the idea of no need to eat until you are full. That is a great point. Eat until you're no longer hungry and just stop eating at that point. And then a survey that Ellen heard about years ago showed that European countries are finished eating when they're no longer full. So I think, as wise as our grandmas are, and chewing the food 16 times is great advice, but some grandmas really want to see their kids eat and keep eating because it gives them pleasure to see kids eat the food that one prepares. I know that that's true in some cultures, that eating is a sign of love and respect. But also we have to sort of convey the message that you should stop eating when you're comfortably full, not able to eat another bite, but maybe you could eat a little bit more, but you're comfortable. And that's the level of satiety that we want you to reach. And you should stop eating at that point. Okay, so I don't know. Okay, so for the highly food responsive kids, of course, we tell our families, you don't always have to have ice cream in the house. It's okay for the house to not have that periodically. And then if really those tempting foods are around, just keeping them out of sight can also help limit either sneaking of food or that food foraging behavior in kids who are highly food responsive. So they call that stimulus control, just controlling that environment so that kids are less likely to be tempted. Okay, and then Dr. Mani.
Thank you. So we have a couple of take-home points, but I would ask everybody to reflect. And if you have more take-home points or different ones, to please share them with us because we would love to hear your thoughts. What we want you to remember is obesity is a common problem. It's a chronic medical condition and should be treated as such. Efforts should be made to reduce the stigma surrounding obesity. And obesity is on the rise for both children, adolescents, as well as adults. Several factors play into it, but there is an important role of in utero and early life and surrounding environment that affect eating behavior phenotypes. and eating behavior phenotypes could be associated with undernutrition, but are often also associated with weight gain. There are several simple screening questions in clinic that help us identify eating behavior phenotypes early. And we have several strategies, as discussed in today's presentation, on how to combat each phenotype.
All right, and we're happy to take any questions or suggestions. And
Yeah.
been really instructive for me to hear people's approaches to this.
Yes.
All right, thank you. And
I see
yes.
we have somebody who wants to ask a question.
Uh-huh.
Yes, Dr. Newman.
Dr. Newman.
Yeah, hi. Is it okay to ask questions? Or just in the chat? Okay. I was wondering a little bit because I have kind of a weird practice, and I see a lot of children with lead poisoning, and a lot of them also are very picky eaters and have like micronutrient deficiencies, et cetera. But I also, in that group also are kids who are eating in the absence of hunger. So like they tend to be overweight, a group of them, and eating like a huge amount of things like chicken nuggets and stuff like that. And I wonder, like going back to what you were talking about, like kind of the motivators for that, like stress and boredom and fatigue. Has there been any work looking at various, I hate to use the word, has been kind of overused, but like trauma or like some kind of adverse experiences and stuff as a driver for some of that behavior? And maybe that like might give us a clue as to how to uh, help like get to the root of it versus just telling the parents to just feed their kids less or what. Um, thanks.
Yeah, that's a great point, and it is very true. In the AAP guidelines that we link to there's even before they get to intervention, it's like 100-page document. But even before they start mentioning interventions, it's about 50 pages of assessment and risk factors. And one of the major topics, besides things like genetics and hormones and other social determinants of health, is adverse childhood experiences. So childhood trauma, extreme social disruption, these are factors. Oh, that's great. Thank you, Dr. Monty. So it is in there, and it has a dramatic effect. So I do think we have to, but before we start intervening, really take a good history and understand the social circumstances for each child. In our obesity practice in Cleveland, we have a behavioral health specialist as part of the team. And it is amazing how often there are these other factors in place. And we often think, well, it doesn't really make sense to start talking about healthy eating until these other things have really been explored and addressed. So I think it is hugely important. And yeah, we can't overstate how important that is to identify. Thank you for that.
Yeah, thanks. It's helpful, the text you put in there. Thanks.
Okay, so I know that there is another slide about the next presentation. I'll turn it back over to Suhavi.
Thank you so much, Dr. Mani and Dr. Kim, for such a wonderful session. The Parenting at Mealtime and Playtime program is hosting its next training on February 11th at noon with Gina Jones. We will discuss functional nutrition while exploring trends and fads in food and health that Ohio teens are seeing on social media. Please take a moment to scan this QR code to register. You can leave it up for just a second. All right, next slide, please. The Preventive Health Program will be hosting a motivational interviewing series for busy providers who want to strengthen their skills in promoting behavior change in children and families. This four-part series will offer CME and MOC Part 2 credit. Please scan the QR code on the screen to register. And we can leave that up for a moment as well.
I would say that this reminds me, the motivational interviewing, Dr. Mani and I, there was a really useful tool developed by the AAP, and I'll put it in the chat, but it is about motivational interviewing. And it used to be an app you could get on your phone, but I couldn't find it in the App Store, but it's still on the AAP website. And it's called Change Talk. And it's a simulation about motivational interviewing, and it's centered on childhood obesity. And it's such a great tool. And I mean, when I first saw the app, I wasn't that aware of motivational interviewing, but going through this, it really is instructive in that you're meeting families where they're at, and it's a great way to open up the conversation about healthy lifestyle, because some families, depending on where they are in the readiness to change spectrum, either it's not on their radar or it's still too sensitive to talk about. And motivational interviewing allows you to meet them where they're at. So it's a positive experience. And then maybe the next time you see them, they're more open to having that conversation. So that it's a great tool. And this sounds like a great session also.
Thank you, Dr. Kim. Next slide, please. Please check your email to claim your CME or MOC credit. We ask that all participants complete the short survey, even if you do not plan to claim credit. This will enable us to collect endpoint data to measure the rigor of our programming. Once you complete the survey, you will receive a certificate within 10 days, and I will follow up with these directions via email for your reference. Next slide, please. If you have any questions or suggestions for future PMP programming, please call or email me at the contact information on this slide. And this concludes today's training session. Thank you so much for your time and energy, and I hope to see you in another Ohio AAP training.
Thank you.